And everybody in agreement? T45?
Okay, sir.
And it's a left approach. We're on the left side. All right, sir. Dr. Deuk here, okay?
All right, yes, sir.
We're going to get started.
All right, perfect.
So just lay still. I'm going to first give you some numbing medicine. During the beginning of the surgery, when you're still awake, you may feel a little poke. If you feel any discomfort, just say ouch, okay?
Ouch.
You got it. That's it. If you at any time feel short of breath, let me know right away. Okay, we're going to go ahead and get started. So I'm going to be talking as I'm going along, okay? All right, so this is T45. So we have to find the T45 disc. That can be very challenging. Yes, AP. We're going to count from top down and we're going to count from bottom up, just to make sure that we're sure of the exact level. You just lay still and we're going to do all the work, okay?
Yes, sir.
All right, so I would start, that's fine. Yeah, let's go north a little bit more, just there. And maybe a little less dose because he's thin, not a lot of soft tissue. Okie dokie. So there's the first rib there. All right, that's the pedicle of T1, 2, 3, 4. Shot. All right, it's too low. So T1, 2, 3, 4. That's 3, 4. Then down below should be 4, 5. That's too low. I hope that's not in the way. Okay, I believe this would be shot. T45, just down here. Now, before I mark it, so T1, T2, T3, T4, T5. Before I mark it, I'd like to verify that from the bottom. So let's go down to the bottom. Go down to T12, right there. And let's count up. A little bit more. That's plenty enough. Go north a little bit. All right, that's a little too north. Come down about 1/4 inch. Shot. All right, good. So shot. Way high. Shot. 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 Don't move. All right, that should be the pedicle of 12. No, don't do anything. 12, 11, 10. Shot. Shot. And you're pulsing, right?
Yes.
Shot. That should be 10. 12, 11, 10. Let's move up a little bit, just a little bit, to maybe an inch. Shot. 10, 9, 8. Stay there. 10, 9, 8. Shot. Shot. And shot. So that's the pedicle of 8. All right, move up again a little bit. Yes. Hold on. 8. Shot. Yeah, 8. Go a little further north. 8, 7, 6, 4, 5. 8, 7, 6. Stay there. Don't move. Shot. 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 That's the pedicle of 6 right there. Shot. You're doing great, okay? So that is 4, 5 up there. Okay? Mark it right there at 6. With a, no, mark right at the tip. Yes. Perfect. All right, so we know that's 6, and then I'm at 4, 5, based on counting bottom to top and top to bottom. So everybody agree we're doing 6, 5, 4, 5, correct?
Correct, sir.
All right, so that's where we need to be. One of the hardest things in spine surgery is operating on the thoracic spine, because the thoracic spine is very difficult to localize. But we have, honestly, a very good patient. All right, and he's got a thin body, which makes it a bit easier. I'm going to give you some numbing medicine, okay, my friend?
All right, yes, sir.
Yeah, you'll feel a little stick and burn. It's normal. Don't be upset. I know. I know. I apologize.
Oh, it's all good.
So, just giving you some numbing medicine to make this feel better, okay?
Yes, sir.
You'll be happy I did it.
Yeah, I know, sir.
3 cc's. Don't move anything yet. So let's see what we could use as a landmark, so I don't have to do this again. What?
So Dr. Demolsco put the camera, they're going to transfer that patient off to the Advent hospital. They're already at work with it.
Where?
To an Advent hospital. They
That's
put
fine.
them
Shot?
Yeah.
Yeah, I can't fix that. All right, so that is right there. Here. No, the other metal. I'm sorry, just getting my bearings. Shot, we said that's the pedicle of 6, correct? So that would be 4, 5 there. Pedicle of 6. 4, 5. Lateral, we're on the left side, which is good. Huh? What? No. I'm talking to myself out loud. Can you move north just a smidgen? Like an inch? That's good. Shot. All right. So there's that little vessel coming off on the left side there. The patient's right side. On the opposite side of me. That tells me that that is the 4-5 disc. So I won't lose it. You okay, Raph? And then I've got this weird line right in 4. But the vessel is the main thing. Okay, I feel pretty good about that. As far as a landmark. Are you comfy?
Yes, sir.
Let me know if there's any discomfort for you.
All right.
Okay. Sometimes a little bit of plastic gets caught up in there. How does it feel? Shot?
Not bad. No pain. I feel it.
All right. Well, you're a very brave young man.
I appreciate it. It was this or nothing.
You okay? You okay? All right. No, it's okay. I don't want to proceed if we need to stop for a few minutes. That's fine. All right. So now I need a lateral view. And we may have to recount again, and that's fine. I want to make sure we get this done right. What side are you worried about? Yeah, the drape? All right. Wow. Amazing. You're doing great. Okay. So, that's kind of a yucky view. Can you help me do a better job there? I need you to go north, and I need you to get rid of all that airspace that's whiting everything out so I could see the spine. Okay, can you do that? You have to what? I don't know what you're saying. Oh, you just have to, don't you just have to swing your base this way? What's hitting the board? I need you to go north. I don't need much north, just a little bit. Are your arms okay, sir?
Yes, sir.
Let's get a shot. All right. Wait. Interesting. What am I seeing there? Once again, get rid of all that dead space. Perfect. Much better. All right. So, you doing all right? Okay, let me know when you're ready for me to proceed, doctor. Shot. So the question is so overexposed. You got to reduce the amount of emission. It's totally overexposed. All right, that's better. That's better. That is better. Let's go back to an AP. I may want to start a little higher, more north. So, thoracic disc herniations that cause pain are not common, but they do occur. And unfortunately, most people with them are turned away from definitive treatment and care by their doctors because the truth is that they're very hard to fix. They're very hard to treat. And the reason for that is that they're just very difficult to get to, and the spinal cord sits just really near it. So you don't want to injure that. You don't want to injure nerves. So people are generally afraid. Can we bring the blood pressure down a little bit? Are you feeling any discomfort, sir?
I felt a little cold, but
Okay.
that's about it.
All right, once again, I feel comfortable that we're at the proper level. I'm going to verify that again. And shot. Let's go to a lateral. So at this point, I need to get to the facet joint that is just lateral to the disc, just lateral and posterior to the disc, to the tear. And once I get to that facet joint, then I can navigate just past it and get into the foramen underneath the root that's exiting, and then I can, we can get this done. That's better. No, that's better. But if you could reduce it just a little bit more, it would be perfect. Shot?
I had a little poke there.
Uh-huh. Shot? A little poke's okay.
Okay.
Try not to move. You're doing great, honestly. You're doing very well. Shot? But I do feel the facet. I want to get around it. Yeah, I know. Yeah. It's going to be a little bit. I could use your help, doctor. Get him a little more comfortable. Shot. You're doing good. Try to not to tighten up. That's okay. Hey, let's fix the orbit a little bit. Everything's going well for you. So, for those of you, try to fix the orbit to get those ribs lined up. You see them? It'd be nice to get them. Now he does have some, that's good. He does have some scoliosis. You do have scoliosis, by the way.
Yes, sir. I do know.
Was that before your accident or after?
My mom has it, so I think it's like got passed down.
Understood. All right. So,
It's mild though, right?
it is, but it's right where we are.
Oh, great.
All right. We're getting closer to where we need to be. Sean? Now, this must be the superior facet. What is it?
Oh, it's just a little ball that you squeeze. You like it sometimes.
Sean? Beautiful. AP. Now before we go any further, I'm going to verify where we are on the AP view. We got the ribs pretty well lined up. They don't have to be perfect, but we're pretty darn close. And with scoliosis, you're never going to get them perfect. But I'm right at the foramen, just about to enter the disc. Would be nice to see where we are. You know what that means. Don't open the field, just slide your fluoro in. You understand? Yeah. Yeah, looking good. And where's our lateral? There? Yeah, it's perfect. It's really quite nice, to be honest with you. So now we just want to verify our level once again. So let's look north a smidge. So this should be 4-5. Everyone agreement? We want to do 4-5. So there is T1, 2, 3, 4, 5. Let's verify it from the bottom up again one more time. Is that 12 there? Let's see, you're a little rotated. Can you unrotate? I'm going to play that. All right, that looks like L1 and T12. All right, so let's just find out. That should be 12. Shot. Yep, 12. And then 11, 10 shot. That's perfect, 10. Go up. That's 10, then 9, 8, wait. Shot. That's 8, stay there. And shot, that should be 8. And one more time, 8. Perfect, now go north. And shot. Shot. No, don't go north. I didn't want you to go further north. Just stay where you are. Shot. All right, so 8, and then we got 7, 6, right? Shot. 6, that should be 6 right there. Then the one above is 5 and 4. Everyone agree? I love it. Okay, so we're where we need to be. All right, back to a lateral, please. Sir, everything's going really good for you.
I'd like to hear that, sir. Thank you.
I think 5 more minutes and we'll be able to put you to sleep as long as we continue to have good success here. Just relax, just breathe gently and deeply and you'll be fine. We're just going to finish this up. We're too far to the belly, so you need to come up higher. A lot higher. I don't know why, but yeah. Shot. I would go north. Further north, and let's get a nice view again. Let me know when you're ready. Can you scoot back, please? Let me know. It's looking pretty good. It's definitely looking better. Yes, I like it. Nice job. It's good enough for government work. right? Okay, are you comfortable, sir?
Yes, sir.
All right, we're gonna.
That's a Discogram.
What's that?
Oh, no.
We're just trying to get to where we need to go safely.
Okay, I heard that. Sorry. I was speaking.
I'll tell you.
Yeah, I was speaking too soon.
Thank you.
Shot. Yeah. Are you okay?
Oh, yeah, I had a little poke there.
Everything's fine. Shot. Just right there. Very interesting. I think we are needing to go north a little bit. Ah, yes, of course. You doing all right?
Yes, sir.
Shot. There's an old saying, good things come to those who wait. Let's go, AP. You are witnessing history, my friend.
Absolutely. Nothing else is going on.
No one else in the world has ever done this. Thoracic disc herniation via endoscopic transforaminal approach. All right. Well, we're definitely lateral in the disc. Well, let's see what we've got. Okay. Are you comfortable?
Yes, sir.
No shortness of breath?
No, sir.
Let's get a shot. I think we may need to just be a little bit more medial. Yeah, I think so. All right. Well, we're very close to where we need to be, but I think we can do a little bit better. Interesting. Let's get a shot. Yeah. Mm-hmm. Shot. Let's go with a lateral view. So I want to start a little more lateral. And hey, will you do me a favor, John? Or who has the white arrow? You do. Here. Put the white arrow on that disc. Just there. And leave it there. Okay. How's our blood pressure? 136? Can we lower it?
Working on it slowly.
Okay. Let me know when you're able to bring it down just a little bit. You okay there? If anything, I want to go a little more lateral. a little bit. That will help us get to where we need to go. Shot? So nice to have that. Shot? So nice to have the arrow.
Oh, yeah.
You're doing great, by the way. Where do you feel that?
In my back.
Okay. Shot. Try to relax. You're doing really good. Shot. Let's see if we can get those. You know, I think we have a little bit of orbital rotation. You're doing great. Just relax. Yeah, that's a little better. I can't give you too much numbing medicine there. I'll give you a little bit more to try to make it a bit more comfortable. Might help things a little. Shot. Shot. You okay?
Yeah.
Shot.
I feel it though.
I'm sure. Just relax. Everything's good. Shot. Shot. Uh-huh. Shot. Shot. Okay, let's get, give me 1 second, then I want to get an AP. That looks good in terms of the trajectory. AP, don't move, don't move. You're doing really good. We're almost done, I promise. I was almost there and I wasn't really happy with it, so I decided to change it, and I'm really much happier right now with this. So you're doing, yeah, you're doing really good. Just hang in there. All right, back to a lateral. That looks perfect. You like it? Yeah. Oh, let's verify one more time. Sorry. Let's go back to an AP. I'm sorry. Let's just go verify up top. I'm 99.9% sure this is T45, but I want to look up at the top at the first rib. You got to go north a little bit. Just a little bit. Shot. Okay, so let's see it. Yeah. And it's T1, 1, 2, 3, 4, 5. I got 4, 5. Let's go back to a lateral view. So we're in the right spot. We're just really close. I like to make it as perfect as I can, because if you go as good as you can, then you know you've done the very best no matter what happens. And I think this is going to go very well for him. So we just almost there. Perfect, yeah. So you can see we're right there behind the disc in the foramen, just above the pedicle of T5, and are you comfortable?
Yes, sir.
All right. Shot. We're literally at the herniation right now. Shot. Now we're inside. Are you comfy?
Yes, sir.
I felt a tear, by the way.
Can you tell this is like a big tear or?
Oh yeah, it's a big tear.
Oh, wow.
A lot of scar tissue too, Sean. Mm-hmm. Which is okay, because we'll take care of it. It looks like some of the dye is maybe even leaking out. I just can't get it to move. Give me an AP. Perfect. Yeah, it's really good. All right, let's go back to a lateral. Very happy with that. Everybody agrees T45? All right, we're going to be able to put him to sleep. I need just one more minute. Give me a second here. Yeah, give me the stylet. So in a minute, we're going to put you to sleep, okay? And, pardon me?
I said discogram.
I'm trying, but if you get too much scar tissue, Sean, believe it or not, the discogram can actually, you may not be able to do it because of all the scar tissue. And that's what I'm experiencing is that. So,
Scar tissue from only 11 months.
oh yeah, inflammation can cause
That is-
lots of scar tissue.
You wanna throw the guy away?
Yeah, that's a good idea. Let me see. Just can't get any to come out. It's weird. Yeah. Yeah, it forms like a casing. Shot. Make sure the needle is clear. It is. Yeah. If there's a lot of pressure in the disc from inflammation and scar tissue, yeah, it can be really difficult to do. That is your case. It's amazing. Honestly, I've never seen it so hard. Shot. So the only thing I can do is try to pull it back a little bit. Shot. That might help us. It's just amazing. Yeah. Shot. Yeah, it's amazing. I just can't get any out. Shot. All right, so when you felt me go in the disc, did that feel like your typical area of pain?
Yes, I believe
I honestly just I can't push any of the dye out. I think you're just, I don't know, maybe it's under too much pressure. As a matter of fact, I feel the pressure. It's pushing the guide wire out. So, Sean? Yeah. All right, let's try. Let's see what we can do. Try one more time. I would love to get the discogram done, but if I can, I can't. That's amazing. All right. Well, we're going to put you to sleep and get this thing fixed, okay? I couldn't get the discogram done because the dye just won't come out. Take a shot.
you'll still be able to see all the herniated parts.
Oh, yeah, when I get in there.
Okay.
Mm-hmm. All right. I want you to count from 1 to 100 out loud, please. Lay still and just count from 1 to 100 out loud. Sean?
1, 2, 3, 4,
Sean?
5, 6, 7, 8,
Keep going. You're doing great. Sean?
10, 11, 12, 13, 14,
You're doing good. Keep your head still. Keep counting. You'll feel a little burning in your arm. That's just the medicine going in. Keep going. You're doing great. You're doing great. All right. So he is asleep. Very interesting. Honestly, just could not get. Lay still. Could not get any dye out whatsoever. So unfortunately, we don't have a good discogram. But, you know, when you look at his MRI, it's the only herniated disc he has, and more importantly, it's quite literally right where his pain is. So it's a small herniation, broad-based tear, but I believe there's been a lot of inflammation in this young man's disc here, causing the pain. Shot. So he traveled from Jacksonville. Shot. How's he doing? Good? All right. Thank you, Luis. Yeah, the dye can be sticky. So, thank you. Shot. All right. Sats are good. Shot. Good. That makes me happy. And I tried earlier to get into the disc, and I just couldn't because my angle wasn't right, and now my angle is proper. And I was able to get just lateral to the facet joint and just under the rib head and under the nerve root. Shot. So here we are at the back of the disc. I can actually feel the herniation now. And it's read as a small herniation, like a bulge, and that's what I'm feeling. So that's consistent with what I'm feeling. Shot. All right, so now we're still on the guide wire, and you can see the angles at about, I don't know, maybe 45 degrees. And I'm going into the, let's get one more shot, then an AP. Feel like it's going through the tear right now, through the annular tear. I got it, don't worry. Yeah. And he's nice and asleep, he's comfortable. We've lost literally half a drop of blood at most. Let's narrow up the collimator and get a shot. Low energy. That's perfect. My God, that's perfect. The tip of the dilator is quite literally right. You can go lateral. Right at the lateral border of the disc, right where the tear is. Just lateral to the spinal cord. We're in the what's called Camden's triangle. The exiting nerve root is above us. The rib is above us and below us. You know, so the T4 ribs above us, the T5 ribs below us. We're right at the interpedicular line, about to go into the disc. Okay, so it's as perfect as it gets. How's he doing? Doing great. Really hope this works for this young man. He's got nothing else. You know, he was injured on the job. Nobody helped him. Nobody could take him serious. They all thought he was just making it up. But we knew when I saw where his pain localized to, and I saw the small herniation, I knew this was it. Shot. All right, so neurosurgeons around the world cringe all you want. This is transforaminal endoscopic surgery at its finest, microsurgery at its finest. And this kind of patient would travel the world and visit every neurosurgeon around the world, every orthopedic, and no one would be able to help this patient because they would never put this patient through a thoracic fusion, which is a massive surgery to treat this condition. So he's lucky he found us, and we're going to go in there with a 4mm incision and fix this disc. By the way, for those of you watching, this is the tubular retractor, slides down the dilator. The whole surgery is done through this 4mm retractor, and it's going to be done with a laser. A laser. Right, Monica? Monica loves lasers. She's got a shrine at home in her garage. She saved every laser fiber we ever threw away. I've seen her rummaging through the garbage outside on the weekends. I'm kidding. Monica's the head of diagnostic imaging. She's awesome, and she's here helping us with this wonderful patient. Okay, there it goes. I can feel it sliding. Shot. I'm just happy that we have this to offer people, you know. This is it for thoracic herniations that are painful. There's nothing else. The other types of surgery, if anyone even takes you serious, are so rare, so rarely done, and so major that it's so hard to really find anyone that can do them. Any questions, John?
No, none at this time.
Okie doke. We are bringing this down, this little tube, and I need to advance it to the disc, and then we'll go into the disc. Is he relaxed? Like really good? Shot. Oh, by the way, post-op patients with pain, anti-inflammatory is fine,
Okay.
rather than fentanyl or something sedating. Shot. Okay, so we are heading in. Shot. Very nice. I don't want to hit your finger. Shot. Very nice. Shot. Yes, yes. Now we're dragging the dilator forward. So I'm going to stop with that and get the dilator out. And then we're ready to do surgery. Shot. So here we are. We're well inside the disc. And honestly, I've actually shoved some of the herniation back in the disc. So we're going to go fetch it and eliminate it. This is number 11, folks, in my career. 11th endoscopic transforaminal thoracic disc repair. I would never have dreamed of doing this surgery more than 2 years ago, but I've had patients come to me begging me to do the surgery on their thoracic herniations, even though I've told them it's risky, it's never been done, and they're in so much pain and there's nothing else for them to do. Literally nothing. And the sad thing is I've had them even say things like, if you don't do it, I'd have to kill myself. Okay? So this pain is horrible to live with. It's sharp. It feels like a knife stabbing you. And everyone else just blows these people off. Surgeons send them to the pain management doctors. Pain management doctors send them to therapists. Therapists send them to psychiatrists and pain management doctors and back to surgeons, and they literally go round and round the merry-go-round and never get fixed. So I'm hoping to fix him today. And let it be a message to everyone. Find hope. Don't live with it. All right. Again, you're watching a live stream from Deuk Spine Institute. We don't edit our videos. We show you everything, so even if I screw up, you'll be able to see it. Okie dokie. Here we are inside the disc. It is blurry because I need to focus this endoscope. And I want to get it focused. There we go. It's a little better. There it is. You can see the laser fiber. I'm going to pull that back a little bit to get it optimal for my visualization. It's about right there. And we're ready to get started. We are inside the disc and we're going to start zapping this thing. The first thing you can see is even though we couldn't get a discogram, there's still some blue dye that got out. Remember, the blue dye comes from my employees. Their veins. They're Deuk Spine employees with blue dye. Right? They bleed blue.
We sweat.
Royal blue. Sweat. You sweat blue?
Yeah.
I don't want to hear about all the body secretions that are blue. I just figure blood is good enough. Blue blood. All right. So, anyway, the dye that we use actually stains the degenerated nucleus pulposus, okay? And how do you get degenerated nucleus pulposus? There's only one way. Inflammation. Inflammation. And this patient has inflammation going on in this disc. So it's just more evidence of what's happening here as being inflammatory, and that's what's causing his pain. I feel good about it, even though I couldn't get a discogram, and I can see why. This is all scar tissue. See the yellow calcium? You don't get that without inflammation. You don't get the blue dye nucleus without inflammation. So we're dealing with a chronic inflammatory process. He injured his back 12 months ago. So this has been going on for a year. And he was making the comment earlier, you can get that much inflammation in a year. That much scar tissue? 100%, yes. And it's not just the scar tissue. It's actually the swelling. See, inflammation causes swelling. If you ever looked at a pimple or something that's, inflamed, this scope needs probably to have the fibers reglued. Luis? When I flex it, it's actually losing focus, so the fibers are going out of focus. Can they repair these as well?
Oh yeah.
Perfect. I would just send it in and have them look at it and let us know what they think, but look how it's in focus, and then I bend it a little bit, it goes out of focus, yeah. So I think the fibers are sliding in and out of focus. I mean, it's fine, and I can do the surgery, no problem, but I'm just saying I would get it repaired.
Yes, sir.
Yeah. All right. Yeah, before it gets unusable. You can see the end plate over there. Patients breathing on their own. You can see the respirations and what they do for inside the disc. Breathing increases intradiscal pressure. So this is all the tear right here. This is the part causing the pain. We're getting rid of it. So, good news, we confirm that this is indeed a damaged disc. And you can see the blue dye indicating nucleus herniation. Not a big one, small one, not like the lumbar where you see a lot. This may be stimulating for him, so be prepared to keep him comfortable, please. Dr. Rafferty. Yeah. And those flashes you see are the laser energy interacting with calcium deposits. And the movement of the disc is, his breathing and coughing. Did people know that when you cough, it increases the pressure inside a disc? So that's what you're seeing. Breathing and coughing. It's pretty interesting. Yeah. So he's just coughing there. Any questions about the surgery?
Yes. What are some of the challenges with a DLDR in the thoracic spine that are different from those in the lumbar or cervical spine?
Yeah, great question. So what are some of the challenges of this particular thoracic Deuk laser disc repair? In my opinion, it's the most risky and dangerous of all. And so that would be the number one challenge. The discs are smaller. The discs are harder to get to. The pathway for me to get there is very narrow and very risky. Specifically, the lung. The lung is right here. We're going just medial to the lung, just to the inside of the lung. If I hit the lung, then it would drop his lung. He would get what's called a pneumothorax, and he would not be able to ventilate that side of his lung. His lung would collapse, so we'd have to go to the hospital and get a chest tube put in. This happens spontaneously in some people. I know a doctor, as a matter of fact, who just had this happen to them. That doctor was at a dance and was dancing and at a party, and then had a spontaneous collapsed lung. It's called a spontaneous pneumothorax, okay? So, but in this case, it wouldn't be spontaneous, it would be surgeon-generated pneumothorax. So I would have created it with putting the needle in. So, okay? But that would be really bad. But it's a known complication, and it's manageable. Okay, it's manageable. We ventilate them until we can transfer the patient to the hospital and then get a chest tube put in. So, another is there's blood vessels here really close to where I'm working, that are very risky and dangerous. There's the tear, by the way, in case you're wondering, the annular tear. And that's what I'm working on with the laser. I'm debriding it. So now it'll heal. It'll take his pain away and it'll heal. I can't wait to see him back tomorrow in the clinic to hear what he has to say. I'm very excited for him. I think he's going to be very happy. This is all scarred up tear. I know the visibility isn't great, but I can see it and I can feel it. The other challenges are the blood vessels. You know, the heart is literally right near where we're operating. There's no margin for error. If you mess up, I can't even think about that right now. We're just a few millimeters away from instant death, basically. So yes, I'm not trying to scare you all, but the truth is I make these surgeries look a little easy, but the reality is that they're very serious surgeries. And look at that herniation right there. And I wouldn't do them unless the patients were in so much pain that it would have to really be impactful for their life. And it is. When I fix these and their pain goes away and they come back the next day and they're crying because their pain is gone, I mean, that's what else, I mean, what more in life could you ever want from your patients but their happiness and joy? And that's just why we do it. You know, I take this risk because, not because I need to, but because this patient wants me to. And if this works, which I believe it's going to change his life. He's a young guy, you know, he's a young guy, and if I didn't do this for him, he's going to be on narcotics, painkillers, OxyContins the rest of his life, and then eventually, you know, end up on the street with heroin addiction and doing fentanyl and heroin, you know, to ease the pain, and totally addicted. And if you think I don't know what I'm talking about, then you need to go and learn about what happens to people who are in chronic pain that get, you know, narcotics prescribed by doctors for years, and then they end up on the street because they can't work, they can't afford to pay for the painkillers. They just become totally dysfunctional. And I don't want that to happen to anyone. No human being should have to suffer like that. If that was my kid, I would do this same thing for my son, my daughter, to give them a pain-free life. So it's very deep and personal for me. I hate the fact that my colleagues think it's okay for people to live in pain. I hate the fact that my neurosurgery colleagues think that, you know, taking out half a brain tumor and then the person still dies from it is like, you know, what they live for, when you can actually make a massive impact on people's lives by fixing their pain. That's what I focus on. And it's really weird because when I got interested in neurosurgery at USC in Los Angeles, I talked to Marty Weiss, you know, the head of the neurosurgery residency review committee. And Dr. Weiss asked me, he said, you can go anywhere in the world you want to be a neurosurgeon. You have the highest credentials, the highest grades, the highest accolades. What do you want to do? You want to do aneurysm surgeries? You want to do brain tumors? You want to do all these sexy things? And I said, I want to treat pain. And literally, I thought he had an apneic event. He stopped breathing for a second. He's like, you want to do what? And I said, I want to get people's pain, get rid of their pain. And he said, pain, you know, you don't want to be a pain surgeon. Those people never get better. Those patients never get better. We can't fix them. And back then, there was really no way to fix them. Fortunately, spine has changed since I started doing it 26 years ago. And now I can cure pain. So, you know, I guess this is God's plan for me. And I'm happy with it. And I love Dr. Weiss. He really helped me. So I don't mean that in a bad way. But neurosurgeons in general, they're so focused on themselves and glorifying themselves that they don't actually think about their patients, you know, and their needs of the people they care for. And I don't mean that for every neurosurgeon, obviously, but a lot of them are that way. And that's what's so disappointing. Even the ones that I trusted are that way. And I tried to teach them this technology. Ooh, there's a puddle of water at my feet. And they just didn't listen. They just don't listen. They just want to keep doing their silly surgeries that don't really help people that much. Yes, I said it. It's true. I've seen so much harm come from neurosurgeons operating on people right in front of me. People dying during surgery from carelessness. And it just kills me to see that. So yes, I strongly oppose most of my colleagues and how they treat patients. I don't share their philosophy. I have my own. What's called the patient-centered philosophy. I do what's best for my patients. All right, what other questions are there? We're almost done. I'm just about done. Probably another 5 minutes max. I'm almost out of the disc. You can see all this scar tissue. Amazing how thick it is. So dense. So, yeah, this poor young man has suffered long enough. And tomorrow, if you watch, it won't be tomorrow. Tomorrow when he comes back, we'll video him, but the release of his testimonial will not be until I can send it off to my videographer who can edit it and make it nice for you all so you all can enjoy it. Just about done. And that's a solid core of scar tissue from inflammation. And that's why I couldn't get any dye. I knew what was there. I mean, once I felt that on the Discogram, I knew what we were up for. I knew it was going to be just whittling away at all this scar tissue. John, another comment, question?
No, there are no further questions at this time.
Fantastic. We are putting the last touches on this. There's a herniation there. I don't know if you saw that thing crawl out of the wall, but pretty cool. There's the fat around the spinal cord, just under the nerve. We are pretty much done. Let me just get this lateral piece here. Yeah. Funny. Lovely. Absolutely lovely. That's it. We're done. Yeah, he's feeling it. Wow, imagine, look at all the damage here. This present here, you know? Can't tell this on the MRI. I'll be honest with you, if I had looked at that MRI, I would have probably missed this as well. And I do this for a living. You know, it's quite amazing, to be honest with you, just how much damage there really is. How significant it is. All right, done.
Lights on, please.
Hey everyone, great job today. Very, very happy. Everything went really well. And I'm proud of you all for doing such a great job. For those of you watching, we have more surgery on Thursday. We actually have a massive fusion, lumbar TLIF, on a patient who has some scoliosis and pain and wanted the fusion over laser. So that's the only way to fix the scoliosis anyway. So we had to do it that way. All right, well, we did the entire surgery through this here little tube. Can you see that, John?
Yes, we can see it.
And this tip of this tube was inside the tear and the herniation at T45 on the left side. And then we brought the scope down through the tube like this. And came out at the bottom with the laser fiber. So pretty cool, huh? If you like it, say cool beans. All right. And by the way, look at this incision here. Literally a tiny little hole. This patient will be out of here in about an hour. If you have questions, type them up and I'm going to come answer them for you. What you think, Rita? Pretty awesome, huh? That's number 11 on thoracics, by the way. Hello again, I'm Dr. Deuk Majan, and we just finished broadcasting a thoracic Deuk laser disc repair, only done here at Deuk Spine Institute here in Florida in the United States on the Space Coast. And what's special about this surgery? Well, for anyone who has a thoracic disc herniation, they'll tell you no one takes them serious and there is no one out there that can fix their pain. Why? Well, thoracic disc herniations are kind of in no man's land or no woman's land. I don't mean to be, discriminatory there, but basically the reason is they're extremely difficult to treat and almost impossible. There's fusions that can be done, and to do a thoracic, to fix the disc, okay, the disc is anterior, it's in the front, right there, that's where the herniation is, and this is the back. So surgeons have to do these crazy surgeries. They're called, you can look them up, lateral extracavitary approach to a thoracic disc herniation, or another one is called a transpedicular approach. And these are extremely damaging surgeries where the incision is usually somewhere around that big. The surgeon has to mobilize the paraspinous muscle, wrap strings around it and literally pull it over to the side, ripping it. Massive carnage, bleeding, pain, horrible pain after surgery from just that. As they mobilize the muscle laterally, then they can do a laminectomy and take out the pedicle or part of the pedicle and facet, and they can try to reach around from the side to get in there and take that disc out. But the truth is, there's no surgeon that would ever operate on this patient because the disc herniation was small. It was an annular tear with a bulging disc, and they would not do it. Surgeons would operate on somebody whose spinal cord's being crushed by a disc herniation. They would do that type of a lateral extracavitary transpedicular approach. A laminectomy doesn't work. A laminectomy is not going to do anything for this patient's pain. Laminectomy is taking the bones and ligaments out in the back of the spine, and its basically purpose is to unpinch a nerve root. Well, that wasn't this patient's problem. His problem was in front of the spinal cord. So if you look here, I'm not trying to make this complicated, but that's the spinal cord right there, okay? It's in the disc herniation's in the front of the spinal cord. So what we did, we came in through the back at about 45 degrees. I went underneath the nerve root, so I came in like this through the muscle, and I got under the nerve root, and I touched the facet, and I went just right in there. It's called the safe zone or Camden's triangle. I don't know if you can see that, and got into the herniation and zapped it out. We found there was a lot of scar tissue here, chronic inflammation. That was not a normal disc. That was a very, very abnormal disc. And I could see why. Because when the disc tore on the outside, the annulus tore, the jelly in the center pushed through the tear and wedged in there. And the disc was trying to heal for 12 months. And that jelly in there is so inflammatory, it caused massive amounts of inflammation in that disc, and that caused the disc to get scarred and scarred up. And when I got in there, yeah, I dealt with a lot of scar tissue, but there was definitely nuclear material still stuck in the annular tear. So we call that interposed nucleus herniation, nucleus pulposus. Long story short, we got the job done safely. This patient's going to do fantastic. He's just a young kid, and he'll never forget what we did for him, and that's what matters. Yeah. Any questions? Have a great day.